Hello, my name is Mary Grady, and I'm a Pediatric Emergency Medicine Fellow at Atrium Health in Charlotte, North Carolina. The title of my research is Comparison of Ultrasound Marked versus Standard Lumbar Puncture Success in Infants. I would like to acknowledge my co-authors, especially Dr. Lindsay Shadowin, who is my research mentor. We know that lumbar punctures are an essential part of evaluating a febrile infant. Having and analyzing the CSF helps us to determine the patient's diagnosis, the treatment duration, with which antibiotics we should treat, and what the patient's prognosis might be. Unfortunately, many lumbar punctures are unsuccessful. Success rates have been documented in the literature from the 30 to 50s percentile, depending on the experience of the provider. These low success rates mean that infants often undergo multiple attempts. They experience more pain and discomfort with the procedure, they are at higher risk for infection, and they may have a longer course of antibiotics or a prolonged hospital stay. There are at least 3 recent studies that have looked at utilizing ultrasound pre-procedurally to make skin markings prior to a lumbar puncture in infants in the emergency department. The study by Dr. Neal showed an increased success when using ultrasound to make skin markings prior to LP. The study by Dr. Gorn also showed increased success when using ultrasound to make skin markings to identify spinal landmarks and calculate a maximum safe depth compared to standard lumbar puncture. Finally, the study by Dr. Kessler, however, showed no difference in the first attempt success when using pre-procedural ultrasound. Given the mixed results of these studies, our objective was to determine if utilizing ultrasound to determine the optimal position and location of lumbar puncture would improve our success rates. Our primary outcome was defined as successful lumbar puncture with less than 1,000 red blood cells by the first provider. Our secondary outcomes included success obtaining CSF with less than 1,000 red blood cells in subsequent providers, and obtaining any amount of CSF regardless of the red blood cell count by any provider. This study was done as a case control study. We had a retrospective group of patients that underwent lumbar puncture using the standard technique of palpation, and we had a prospective group of patients who had an ultrasound-marked lumbar puncture. This study was performed in a pediatric emergency department in Charlotte, North Carolina. Unlike some of the other studies, a large portion of our attendings are general emergency medicine trained, and we have a mix of residents from various backgrounds. We enrolled a convenient sample of patients, anyone under 12 months of age who was undergoing a lumbar puncture. This slide shows how we ultrasounded the patient in 2 planes in both sitting and lateral decubitus positions. We visually identified the largest pocket in both positions. Then, based on the sonographer's impression, we chose the position with the largest CSF pocket to perform the lumbar puncture. These are images that represent the typical appearance of the spinal ultrasound in sagittal and transverse views. The sagittal view shows you the very clear termination of the spinal cord, the conus medullaris, as well as the nerve roots and the CSF. Practitioners reported that it was helpful to identify the end of the conus so that they knew where they could safely perform the lumbar puncture. In the transverse view, you again see the CSF pocket. This view is below the level of the conus. In terms of our results, these were the baseline characteristics of our patients. We had a group of 210 retrospective patients and a group of 74 prospective patients who received an ultrasound. As you can see, the groups were similar in terms of age, gestation, race, ethnicity, etc. Of note, the median age was 25 days in the retrospective group and 22 days in the prospective group. So in general, these were younger patients. We also looked at the characteristics of those people performing lumbar punctures in RED. You can see that more than half of our lumbar punctures are done by first and second year residents. For our primary outcome, we found that there was no difference in success obtaining CSF with less than 1,000 red blood cells on the first attempt in the ultrasound group. We did find that on multiple attempts, which were done by providers with more experience, the ultrasound group had a 51% success compared to 39% in the traditional group. Unfortunately, this value was not statistically significant. The p-value was 0.06. And finally, we looked at obtaining any amount of CSF by any proceduralist and found no difference in the success. In terms of our limitations, this was a non-blinded case control study. The largest CSF pocket was chosen based on an overall impression rather than a precise measurement. We did not routinely use Doppler to definitively distinguish vessel from CSF. Nearly all first attempts were made by trainees. We did not specifically look at large numbers of more experienced providers. This is important because it is possible we would have seen more significant improvement if we had looked at this subset of providers. Overall, we found no statistically significant difference in our primary or secondary outcomes. Our results did show a trend towards increased success using ultrasound with experienced providers. Going forward, we still believe that there may be a role for ultrasound utilization for lumbar puncture in the emergency department. Perhaps we need to look more closely at using ultrasound with a certain subset of more experienced providers who may be better able to incorporate ultrasound into their practice. In addition, as ultrasound becomes ubiquitous, we may also consider looking at using ultrasound in real time with lumbar punctures. These are the references cited in this presentation. Thank you very much. For any questions, my contact information is listed on the slide.